This is Sungan Lee from Korea. So, first of all, thank you very much for this wonderful meeting, inviting for this session. I'd like to introduce the first speaker, Adel Eniman. What is your title? The main topic is how to use ultrasound for femoral approach and complication and bailout. Dr. Adel.
Thank you very much.
Please.
Thank you very much for the invitation. So I will just, okay, I have my slide. So my first talk is about the indication and the contraindication for the femoral approach. First of all, thank you very much for the organizing committee to invite me to this fantastic meeting. So it's always a pleasure to be here. These are my disclosures. So the first statement is, of course, is that radial access has a big upgrade in the guidelines. It's a 1A recommendation in European and the US guidelines. So it's always the first choice. That's for sure. So why do we still need a femoral access? Of course, radial access is the default approach, but the femoral remains essential in contemporary practice, and conversely is disproportionately needed in mostly high-risk settings, like STEMI and shock, for example, when you have to go for large bore, when you have to use mechanical cardiac support, or sometimes if you're not really a slender operator for CTO or complex PCI, of course, for structural interventions. And this results at the end in a low case volume per operator and relatively poor transfemoral experience over the year. And in these complex settings, it can translate into life-threatening complications. So transfemoral access demands precision, even for a simple case. So in other words, we need to keep expertise in femoral access. So how to perform best femoral access? It always begins with the best access for femoral practice. So the first step is to understand the anatomy and have a clear idea of the target entry zone, which is the common femoral artery. And this is very simple. The target area, which is the common femoral artery, is located above the femoral bifurcation and below the nadir of the inferior epigastric artery. And this is very simple to understand, that if you puncture the femoral artery, you must always puncture an area that is compressible. So always assume that manual compression can be necessary if your closure fails. So this is extremely important, and this is probably the main message that I want to give with this presentation. Why? Because if you are in a compressible area, whatever happens, if you fail your hemostasis, you still can compress the femoral artery because you have a bony structure, which is the femoral head and the pelvis below the artery. If you puncture too high or too low, what you do during the compression, the manual compression, is you just displace actually the artery upward or downward, but you are not actually performing hemostasis. So if you are too high, you will end up with retroperitoneal hemorrhage, and if you're too low, you will end up with probably a false aneurysm. So it's very important that you puncture into this compressible area. You need also to understand the anatomy, because not all the bifurcation are located below the femoral head. So in the vast majority of the case, the bifurcation is below the femoral head, but sometimes it's just at the level of the femoral head, or sometimes even above the femoral head. This is the so-called high bifurcation. So probably you need to screen the patient with the echo, or if you have a CT before, to understand where is the bifurcation. And if it's extremely high, sometimes you have to go to the opposite side, or even you have to puncture the superficial femoral artery because you want to be at the level of the femoral head. The most accurate way to puncture is to use echo. That will be the subject of the next talk, but this is extremely important. So usually you will use two views, the longitudinal view to check for the height, and on the same view you can see the femoral head, you can see nicely the height of the puncture, and the second thing is to go for an axial view when you're sure that you puncture really the anterior wall and the roof of the femoral artery. This is extremely important, as Fuminobi has said, for a good hemostasis. And also what I do usually, I call that the chip test, is when you have puncture, you have to document the height of your puncture. It's extremely important because if by inadvertence you are too high or too low, you need to anticipate the complication. So can you use, for example, fluoro instead of echo? Of course, it's better than manual palpation because manual palpation never tells you where is the bifurcation or where is exactly the common femoral artery. So this is another way to have a more accurate puncture, not as good as echo, but this is at least better. But also it is associated with increased radiation. It is strange to see that the ultracolor trial, which was designed in patients using large bore access for femoral, that we could not show a significant benefit of using ultrasound as compared to angio-guided puncture. But there was a trend which was almost significant for less vascular complication, and also the first pass puncture was also increased with the femoral access. The situation where the femoral access is extremely dangerous is the obese patient because you have this increased distance between the skin and the entrance of the artery. So even with a 45-degree angulation of your needle, the distance between the skin and the puncture site can be extremely long, and there's a high risk of puncturing the artery too high and to end up with this situation where you have to do a bailout actually, because if you fail your hemostasis, first thing, you cannot use manual compression in this case, so you have to go for a bailout, like for example a stenting or something like that. And this was shown that echo guidance is better than manual palpation and is better probably than even fluoro, and especially in those cases when you really need it, like the obese patient, the patient with peripheral vascular disease, or if you have a high bifurcation. This is really the case when echo-guided puncture can really make a big difference, not only by increasing the first attempt success, but also by reducing complication. So I think it should be standard practice for precise vessel localization. And this was also shown in this large meta-analysis, showing that not only it increased the first attempt success, but also it reduced serious complication. So that's very important to understand. The contraindication to transfemoral access are closely related to what you need actually to close the device. So if you are not able to puncture the common femoral artery, so you should not go for it. You need, of course, if you want to do to insert a closure device, to have a certain minimal lumen diameter, and also you cannot puncture the artery if you have that kind of anterior large calcification. That you need to avoid, and you can screen that with the echo to avoid this area at risk, because it's a risk of failure. You need also to think beyond the puncture site, and this was developed, the hostile score was developed in the field of structural heart disease, when you see that beyond the puncture site, you have to look at everything, the tortuosity, the fact that you have more calcification at the level of the iliac artery, if you have any area with a reduced lumen and things like that. Every time you add 1 point to this score, and this score, if it's high, it will not be a predictor of complication at the level of the puncture site, but above the puncture site. And if you create a complication at the level of the iliac artery or things like that, it can be even more dangerous than at the level of the puncture site. So be aware to have a good target zone, but also be aware of what you have beyond the puncture site. So what should be our key messages as a club, for any operator performing femoral access? I think we should recommend first to know your anatomical landmarks. This is not something that we teach on a regular basis to our fellows. You need to check for the quality of the common femoral artery. I think using ultrasound is the best. You should maximize your puncture technique with imaging. So echo is better than fluoro and is definitely better than manual palpation, that we should definitely avoid when you do a femoral puncture. You should document your puncture height by fluoro or contrast injection. You should use long sheet or hydrophilic or stiff wires in case of hostile non-puncture related anatomies. So I think also we should recommend do not puncture without imaging, do not force the wires blindly. I think angiographic guidance is needed in case of any kind of resistance, and never inject if you think that you're outside of the arterial lumen. It can be extremely dangerous during the femoral puncture. So thank you very much. That was my main messages for this session.
Thank you for wonderful, wonderful presentation for the femoral puncture and the complication result depending on the ultrasound and manual fluoroscopic femoral puncture. So, is there any comment or question?
I have a question for Dr. Adele. You said the ultrasound guided puncture is the most recommendation. So, but for the a little bit senior interventionist, we familiar with the palpitate, and so normally your practice for Cori intervention in your routine practice, you is using the ultrasound guided, or you?
I cannot puncture a femoral artery without ultrasound. It's almost mandatory because you know you do less and less femoral. I do structural like many people here. This is, of course, but even for a coronary procedure, even if I have to put a 5 French or 6 French, I use ultrasound guidance because even a 6 French puncture too high or too low can create very devastating complications, not only for structure. So I think, what do you lose by using echo? If you have an echo machine in the lab, I think there's a gradient. I will talk about that tomorrow. There's a gradient about the use of echo. There's like a hierarchy, you know. I think for femoral, it should be almost 100%. For distal, probably a lot. For conventional, probably less. But for femoral, I think it's really the way to go, yeah.
Did you found any problem with the imaging guided when you transition from the angiographic or from the route previously practiced at the starting? Any point that you will tell the beginner?
Of course, there is a learning curve, of course. You need to know how to use the echo, how to get a good longitudinal view, how to get a good axial view. There is a kind of learning curve. You can take your time during the case, take your time, you know, to stabilize your echo view, to see your needle coming really at the level of the artery, go for the axial view. This takes a certain time, but once you overcome this learning curve, you become very, very proficient. But of course, it's not natural to do it, so you have to learn how to do it. But especially for a fellow, I think it's very important.
Nowadays, I am an old interventional cardiologist, but at very emergent situation, so I always puncture of the femoral artery without ultrasound. But I have one tip of the direct puncture with only palpation. Check the iliac crest and look at the pubic bone. That line is the through the puncture side. Maybe that line is the iliac artery is located in the femoral head of one of third.
Yes.
So I did always the.
At least if you use fluoro, at least you are in front of the femoral head. That's sure, for sure. But you don't know if you're at the level of the bifurcation. You don't know if you're puncturing a calcified vessel. So you gain more information and palpation, but not enough to be safe enough for the case. Yeah. But it's better than manual palpation, for sure.
So
You're
probably combination usage of ultrasound and fluoroscopy is very important.
Fully agree.
Yes.
Especially in the obese patient.
I have a recommendation for the starter because we get familiar with the palpation and the landmark, skin landmark. And I think for the starter or from the beginner, we will change from the ultrasound to, from the routine to the ultrasound guided. It's easy to get high high puncture because of the ultrasound and the thickness of the skin. And you puncture and you try to find the way, find the vessel, and it's easy to get high puncture. So for my experience, I doing 3 things. The first thing is I doing the bony marker as Dr. Lee recommend, and the second thing I doing the angiographic, and then use the ultrasound. Don't go too high and don't go too low. That will be help us to for about 50 cases for the starting.
That's a good point, yeah.
Yes. Okay, thank you very much, Adele. So we have limited time, so thank you very much. So I want to introduce the next speaker, so Dr. Kamei